Welcome to How to Grow as a Medical Educator, a Stanford EdTech video podcast series recorded in the Stanford Medicine Studio. In each episode, we talk with faculty who are actively experimenting, reflecting, and evolving in their teaching. Our goal is to surface the stories, habits, and practical strategies behind their growth so that medical educators everywhere can learn alongside them. Today, Adam Hain and I are joined by Dr. Anuj Aggarwal, who is a clinical associate professor of anesthesiology, perioperative, and pain medicine at Stanford University. While he is a highly active practicing anesthesiologist and pain management specialist, he is equally recognized for his profound impact on medical education and curriculum design. Welcome.
Thank you for having me. It's an honor to be here.
Yeah. Can you share a bit about your background and how you found your way into medical education?
Yeah. Interesting is before I even knew what medical education was, I knew I wanted to be a physician, and I always knew I enjoyed teaching. So ever since I was an undergraduate, I've taught kindergarten, elementary, middle, and high school. My first job was to be an MCAT and PCAT teacher. And so I through that found a love of learning, but never really realized that there was something such as medical education. When I entered into medical school at UCSF, I really understood and finally found mentors who said there's a whole career path that is medical education. And that was the first time I really thought about this is something that I could do and actually work towards. And so while I was at UCSF, I did my thesis in education, particularly around anesthesia. And I did, at that time, what was called the Advanced Pathway in Health Professions Education to get additional knowledge and training. And that then spun into the work I did as resident and fellow when I came here at Stanford, and then eventually into my current roles.
Oh, wow. And I know that you have a role as a theme lead and a co-director exploring how to build really integrated, cohesive, longitudinal curriculum across multiple years of the school curriculum. How do those, the threads that you've built, support pharmacology throughout the preclinical curriculum, and how did you approach that?
Yeah, I think pharmacology was always kind of my first love. That's what got me into medicine. I worked in a pharmacology lab for 4 years. And so it was really exciting to get the opportunity to really think about, well, what should a physician really know about pharmacology when they leave medical school? Because I think there's multiple ways to think about it. People, I think about it as a body of knowledge that you have to know and then be able to recall. And I think the world has really changed from that. I think we live in a world where we have the tools, and electronic tools in particular, that can actually help with recall and with our memory. And so then the question really is, when you even think about threading something like learning about pharmacology and drugs and therapeutics in a curriculum, well, the point is not just to thread a body of knowledge, it's really to think about, well, what would I want somebody who's graduating from Stanford Medical School to actually know at the end of it? And so it was really through that lens that I actually approached it. I think historically people have looked at pharmacology as a list of drugs or a body of knowledge that you actually have to teach, and you have to check box it to make sure the students have been introduced to it. But I think we've sort of moved on past that. And even if I look at my own career in pain medicine, the drugs that we're using now, many are new and were not available when I was learning my preclinical and clinical training at UCSF in medicine. So the question then really became, well, how do adults learn, and what do I really want them to take away from it? I think there's also this really interesting conversation about the pressures on curriculum in medical school. There's pressures to shorten the amount of time we keep students in class, and I think there's great reasons for that, but the body of knowledge is actually ever expanding. So you've got the pressure of less time and yet more to learn. And so then you have to, I think, really think about, well, if I'm going to thread and correlate the material with all the other areas within the curriculum, their pathophysiology, diagnosis, clinical medicine, doctoring skills, yeah, I think it's really the central question becomes, what do I want them to learn and take away from pharmacology? And that was really the central question that I approached the whole curriculum from.
Yeah, you really had to think about the maximum impact and the really key things that people have to know at those points of the curriculum.
Yeah, I think even more than that, I had to really pivot away from what do they need to know at a certain point to do they have the skills to learn themselves, to become a lifelong learner of pharmacology. And I found that some students could acquire a large body of material, but then they hadn't actually learned how to keep up with the ever-changing landscape of pharmacology. And so really having to think about sort of educational theory principles of, well, how do adults learn? How do they keep on learning? And so sort of thinking about preparing them for future learning as really the principle. I think people approach particularly the first years of medical school as an acquisition of the body of knowledge, but I think I shifted it to really thinking about, no, they're just getting introduced to material that prepares them to continue to learn for their next 5 to 10 years of medical training, that they're most likely not going to actually remember a lot from the first 2 years, but do they gain skills and the conceptual scaffolding on which then they can continue to learn when they actually start practicing clinically.
Yeah, learning how to learn and applying that as they go.
Yeah, and I think thinking that actually different topics in medicine, so pharmacology actually has a different way to learn than the other topics. It's not that just learning for the sake of learning or learning how to learn is one thing, that's actually different for different types of medical skills.
Yeah.
That's curious. Like, do you bring that up like explicitly with the students, like telling them, there is this body of knowledge right now, but it continues to change. And what I want you to walk away with is how to learn and how to keep up with it and give them actual strategies for learning?
Yeah, I try to be actually quite explicit about it. I think one of the most explicit places is for step one. So step one is, the exam that comes at the end of preclinical. And so for the students, it's this test of, they believe, of rote memorization. Like, have I acquired this huge body of knowledge, and then can I perform on a multiple choice exam? And I think that's what they think about it. But I really think about it like, well, what was the whole point of all the schooling that you've done thus far? Why did you get an undergraduate degree? Why did you do science courses in undergraduate? How much do you actually remember from your physics class, from your calculus class, from your organic chemistry class? And the reality they, I think, recognizes they don't actually recall a lot. But if I start talking to them about a physics principle as it applies to pharmacology, they understand the concepts because they learned physics in middle school, they learned it again in high school, and then they reviewed it at a more advanced level in their undergraduate coursework. And so that's the same thing. I remind them very explicitly, we call what they're doing right now UME, or undergraduate medical education, because they're actually undergraduates at the level that we think about their medical training. They're simply acquiring concepts in a body of knowledge. They're actually really still far from practicing medicine and learning clinical medicine. So I try to be really explicit, like, yes, I expect you to learn and memorize and dive deeply in this material, but I also recognize you're not going to recall it necessarily in the future, just the same way you don't recall your undergraduate coursework in all perfect detail, but the concepts that you learned are still always now there if you learn it in the appropriate depth.
Yeah, like kind of like helping them to strengthen that schema, to put the things together, the concepts that they're learning, so that when something comes up in the future, it can kind of build into that as a concept rather than something they just have to memorize.
Yeah, I mean, not that the brain, I should know, like, the brain is not a muscle, but I think about it like learning is kind of like, it's like an exercise. You have to practice it and you have to do it multiple times for it to become comfortable, for it to become muscle memory. It's not just going to come out of nowhere. So, and I think that in an era where more and more things can be gotten at our fingertips through, machine learning, AI, etc., I think that it feels like we should be able to take those shortcuts easier. But for us, our brains can't take those shortcuts. And so they still have to go through the learning process.
I'd like to talk a little bit about the integrating the social justice and health equity thread and some of the work that you've done there, and the vignettes that you've created that I know have been very powerful in the classes that you've taught, and you've incorporated historical vignettes into some of your lectures. And so just curious, when designing these vignettes, how you approached the design and how you sort of made sure that it resonated with the students.
Yeah, I think I sort of building off of what we've talked about, I really think about sort of two principles. One is this idea of preparing for future learning and schemas. So not thinking about like, okay, there is a body of knowledge they have to learn, but what schematically do they need to learn? So thinking about like mechanistic anchoring of drugs. So how do drugs actually work? What are the broad principles so that they can continue to learn in the future? And then for preparing for future learning, really thinking about and showcasing them, well, how has science changed a pharmacology over time? And how do we think it might change in their own lifetimes as well, so that they can sort of see what they're learning is just a sliver in a moment of time and that they'll have to evolve with it. The second for me is this idea of like, what are the core competencies of a graduating medical student? And I think with pharmacology, it's easy to focus on medical knowledge, but I always think really deeply about professionalism and professional identity formation. And I really think, as an anesthesiologist, we sometimes are framed as clinical pharmacologists. And I often think about what does it mean that I'm literally in a profession that's defined by the drugs that it uses. And how has that changed over time? And how do students relate with entering into a profession? So to use drugs as a narrative and a story to understand and show them that they also have a place within this profession, whether they know it or not. I think my students know this, but I have this like pet peeve of when people say like, oh, well, the medicines you're teaching are Western medicine. And I'm like, well, actually, I'm just teaching you a scientific body of knowledge that's actually globally inherited. It's actually a schema that is not owned by a single geographic location, nor is it owned by a single culture. And sort of to show them that what we're learning is a continuation in thousands of years of human evolution. We've always tried to heal and help, and we found that the plants and chemicals in our environment can assist with that. And we're just now in a new sort of place with that in the 21st century. And so I try to use those stories to highlight principles that I hope they will carry forward in their own professions, about sort of inclusion, about the challenges of bringing therapeutics to populations, but also to show them how things that we take for granted weren't always the way that they were, so that they can really understand like, no, science is a continual evolution, that systems can change, that they can change the system as well, and that they sort of belong in this vast body of knowledge, that they're themselves, their own heritage, their own ancestors have actually already played a role in what they're learning.
Yeah. Are there any specific stories or multimedia elements that you find to be most effective in building learner empathy and engagement?
Yeah, I studied video game design in undergrad, and one of the principles that I always took is people get really engaged by surprise. So if you can surprise people, or if you can sort of flip their expectations, that's generally what it sticks. It's not necessarily a multimedia strategy, it's more of a narrative strategy. So to give them something unexpected that they didn't really realize, or to change a story that they thought they knew into something new. So some examples that I really stick to me are when I teach about HIV antiretrovirals. I think it's a really fascinating story. I think students do learn a little bit about the discrimination and challenges of LGBTQ individuals and how that sort of framed around HIV, the HIV epidemic in the late 80s into the 90s. But I think there's also this really fascinating story of how that was actually such a progressive time, and that was predicated on Dr. Anonymous, was a psychiatrist back in the 70s, spoke up at the American Psychiatry Association in a mask and sort of declared himself to be a gay psychiatrist, and how that really led to the delisting of homosexuality as a psychiatric disorder. And that really paved the way for legal rights, because until you took away the medical diagnosis, you couldn't take away the legal restrictions on homosexuality. And sort of spinning that into the story of how Dr. Fauci really spearheaded the NIH and designed new ways to think about bringing therapeutics early on into essentially a national and global pandemic. And that's always surprising because they know now Dr. Fauci, of course, through the lens of the COVID pandemic and sort of how he was both villainized and sort of changing nature of the science during the COVID pandemic. And then when you tell the story in parallel with HIV, you sort of realize, and I think they sort of have the surprise of like, oh, actually, the COVID pandemic was not, of course, his first pandemic, but nor was the public reaction to him the first time he had gone through that. And it's both an element of sort of the repetition of history and of science, but also this idea of sort of his quiet professionalism. and sort of using these sort of examples of both Dr. Henry Anonymous, who's quiet, who actually wasn't known until the 90s, of sort of the role that he had played. And then, of course, Dr. Fauci is sort of like, this role, critical role he played, and then eventually in the development of PEPFAR, which has saved something like 25 to 30 million lives in HIV treatment access, and sort of how many people actually don't know that full story. So it's an element of surprise for them, I hope, and sort of using pictures. So I have a picture of him meeting with HIV activists, and I was asked the students like, hey, does anybody know anybody in this picture? And then they sort of don't expect to, but then they look closely and they clearly recognize him. So it's an element of like, oh yeah, this is not something I expected to hear about when I was learning about HIV.
Yeah. I love that, the power of the unexpected.
Yeah.
And the power of narrative. It's really impactful.
Yeah.
Yeah, that lecture is one I was actually thinking of when we were preparing for this. That whole transition that you go through from all those couple of stories. Your lectures though are really popular with the MD students. They really find them to be really good. Are there other approaches that you kind of take when you're designing a lecture?
I think what I try to be really mindful about with pharmacology is it can come across as a list, right? It can come across as a list of facts. And I always think like, why would you come to a lecture? Why would you watch a lecture if it's a list of facts? Like you can get that from 100 different resources.
Right.
So I always have to think about, well, my lecture has to add something of additional value that you could not get simply from typing in this topic now into an LLM and asking it to teach you. What is it not going to be able to teach you? And so I think about drugs in a wider context, and I really think about the narrative, the storytelling. So I also like to, when I think about teaching, think about, okay, I'm not really trying to teach them facts. I'm trying to show them how I understand and how I retain the material and how I think about it. Somebody who, I guess I have to think about myself truly as an expert. So as an expert, I have to model for them how I actually think and process this information. So the lecture is not necessarily about a conveyance of facts. It's about taking a set of facts and showing them how do I think about it. What do I not still know about it because the science is still unsettled? And with that uncertainty, how do we move forward? And so that is, I think, much more complex. And I don't think that's something you can really get from a textbook for a list of facts. And so I sometimes have to be really explicit, like there are topics we don't cover. And I don't cover them because I think you are all capable of self-learning. If you get into Stanford Medical School, if you get into medical school, there's a certain degree of like, I can trust you to learn and you have to learn on your own. So the limited time that we have is going to be spent more on sort of this cognitive psychology of modeling and having you see how I process and think about the information so that you can start getting your own insights and you can start chewing on that information in a similar manner.
Yeah, that's really interesting. Like instead of presenting facts, like you were saying, kind of showing them how to go through the existing resources that you might find to look for all these facts and how to really critically think about what your problem is and how you're going to solve it or what they're looking for. So really way higher level of sort of critical thinking.
Yeah, and I think, I think a lot of people think about like, oh, well, with AI, like, what's the point of a physician? What's the point of learning all these things? I think, if anything, it's just a much more advanced tool. And I think with that, I always have to think about actually the demands on us as physicians are going to start increasing. So you actually can't get away with just knowing the body of knowledge. You actually have to be able to manipulate the body of knowledge and know its weaknesses and know its strengths and be able to evaluate it critically. And so that's what I really try to sort of anchor the lessons on. Like, yes, there's this core mechanistic understanding you need to have the drugs, but can you apply and manipulate that knowledge in novel situations? And I think that's really like the identity of the physician. How do they use medical knowledge? We think about physicians using medical knowledge to heal and to treat, but actually a lot of individuals do that, right? Like medicine is a team, and there's a lot of healthcare providers. So a lot of professions use knowledge to heal. So what's the unique role of the physician? I really think about the physician as the leader of the team and for them to be able to solve and think more critically when there are no answers. And that requires not only knowing the body of knowledge, but then being able to manipulate it quite creatively. So starting to model that within their preclinical curriculum for them.
You're also very well known for your chalk talks and just delivering these well-designed lectures. And so I'm just curious, is that modeling part of the Chalk Talk, or could you share a little bit about why you like doing Chalk Talks?
I think the real secret of why I like doing Chalk Talks is because they're easier, because you don't have to prepare them ahead of time, actually, right? Like with a PowerPoint or any multimedia, you have to have prepared it ahead of time and edited it. And so like it actually takes more time, I think, actually to get a PowerPoint ready. For me, I grew up sort of teaching with Chalk Talks. Like when I was teaching in kindergarten, elementary, middle school, I would always just have a whiteboard. And even when I did MCAT and PCAT classes, and even when I taught at UCSF, that was just what I always did. I always just had a board and I always just taught with it. I think the problem sometimes with PowerPoint is it restricts us because you've already predetermined what you're going to teach and it doesn't allow a lot of flexibility. And there's actually some educational theory about like the way PowerPoints work actually like make people think only in a certain way versus what I really think about is the narrative of what I want to convey during whatever amount of time I have. And so sometimes I actually don't plan my Chalk Talks as much as I think people think, because you don't have to. If you're really focused on the narrative, the Chalk Talk just becomes a tool to anchor a conversation rather than it being the focal point of conveyance. So I think sometimes people view PowerPoints as like, I have to convey what's in the PowerPoint to you. And I think that's the weakness of the PowerPoint versus when I do a Chalk Talk, the Chalk Talk and what I'm writing on the board is not like I have to convey what's on the board. It's just an accessory for us and process for us to go through the story together. So I think of learning as more almost like an oral tradition rather than it being like a visual tradition, ironically.
That's really interesting. Like they're kind of taking them through that. It's the same thing we were talking about earlier, like kind of showing people that critical thinking, like how are you taking all this stuff that's out there and chewing through it yourself and showing them how you do it so that they can begin modeling it.
Yeah, I really think about the Chalk Talk as a way to show what's happening in my head rather than it being a tool to convey information. And what I really like about the Chalk Talk is I can then modify what I'm saying and showing based on the questions that people are asking in class. I think students feel much more open to asking questions as well, because I think with the PowerPoint, they recognize there's a set agenda, but with the Chalk Talk, there's all of a sudden not a set agenda. Like there are learning objectives and there's clearly a goal, but they feel, I think, more empowered to direct the conversation, which I think is super important when we think about like, well, why would you show up to a lecture when you can learn the material also on your own when there's so many other resources available?
More opportunity for interaction and engagement that way as well.
Yeah, and I can also like modify the lecture in the moment, and I've done that very, very frequently. I've taken the lecture in a completely different direction, or I've talked about a topic that I wasn't even planning on for that because it became very evident that the students were interested in it, and then it became a moment for them to anchor onto the broader principles and material that we wanted to cover that day.
Yeah, it's really hard to diverge in a PowerPoint. It's very linear,
That's the I think that's really the problem. I really think about learning pharmacology as almost like coming from the center of a topic and then branching out from it rather than it being linear. And I think that PowerPoints sort of have that weakness, but I think students have become so accustomed to PowerPoints, it's really hard to break them from that as well. So there's a little bit of a give and take there.
I know you have a passion and a background for health professions, education, pathways, and mentorship, and have been involved in the Educator for Care program and teaching clinical reasoning and bedside manner. So, and this kind of also comes back to what you were saying about AI before, but just as technology becomes more and more prevalent and AI supported diagnostics, just curious how you see your role in the E4C program evolving to ensure learners are still mastering that human component and that interpersonal art of medicine.
Yeah, it's a big question. It's a big question. It's hard to actually sort of frame what I think, but I think my role as an educator for care is one of like my greatest like passions in the sense of like I feel really lucky and privileged that I get to have this role where I get to see students from orientation to graduation and really serve as an individual who not only teaches them what I think primarily my job is medical knowledge and my roles as, associate course director for science and medicine and directing the pharmacology curriculum, but really to teach them what does it mean to be a physician. And so it's the same thing. Like there's these core skills and technical acquisition of doing the physical exam. Mm-hmm. How do you do the interview? How do you present? But at the broad scale, it's like, well, why? Why are you acquiring these skills and who do you want to actually be? And so I think as an educator for care, I think, yes, we think about role modeling, but I don't think it's enough in medicine to think that this is just going to happen because they're around you or they're observing you. I think it's really challenging to think about how do you explicitly communicate values and how do you explicitly communicate values that aren't, not that paternalistic is the right word, but I think that's been a concern in medicine that we sort of want people to give up their identities and adopt a new identity as a physician. Mm-hmm. And in that, there's a lot of historical and cultural nuance and challenges. And I think it's challenging to sort of be like, actually, we want you to bring your identity into medicine, but medicine is also going to help forge your own identity. And you have to mix the two and sort of show them, well, how did I do that for me? And how can you find your own path to that? Because there's no one path. And I think that's what's so challenging about that. So when we're doing things like their first interview with the hospitalized patient, when we're doing things like, all right, how to use the otoscope to look in the ear, it's not just about getting through the task. It's also about thinking in each of those scenarios, can I convey values to them, or at least get them to think about values. Who do they actually want to be and what type of physician do they actually want to be? Because at the end of the day, we don't control that. We can hope and we can model and we can gatekeep, but at some level, we empower them to be who they're going to be once they graduate. And we've seen physicians, and our profession is defined by the trust in it. We've seen physicians use their knowledge and power for horrible things. We've seen them use it for great things as well. And it's important that we highlight sort of the nuances of what they're actually gaining and what do patients really think of them. So I think it's something that it's one of the areas where I continue to think the most about because I don't actually have these answers for them either. And I try to have them join me on that journey. Like I'm actually still figuring out the type of physician I am. Maybe I've thought about it more than they have just because I've been doing this a lot longer. But I think sort of showing them that I am also uncertain about clinical scenarios. There are patients who trouble me that I think about that I'm not sure I did the right thing. And that, not that it's, that it is okay, right? And so sort of show them that they don't have to have all the right answers, but how do they fit into this profession and how do you continue to try while being true to yourself and taking care of yourself?
Yeah, it's the journey, not the destination.
Yeah.
And that authentic individual growth.
Yeah, and I think as much as they hopefully learn from me, I always try to show them how much they teach me as well, right? That they are now my colleagues. And that's why I am invested in them. They're not my students alone. So I try to actually be very explicit. I often refer to them as like, oh, my colleagues or your own colleague, like your colleague said this, really to understand that they are entering a profession. I think sometimes that's also really challenging for them to think about, these are individuals who have been at the top of their academic achievement for essentially their entire life. And now they're going into an academic environment, but it's not really an academic environment. It's a professional school. And I think that is sometimes challenging for them to really understand like, oh, we're actually in something slightly different than just a school. We're actually in a professional training ground. And medicine still, even though the word has disappeared, really is an apprenticeship. We've formalized it through the match and through residencies and all these sort of structures around it. But yet, we actually haven't changed how physicians really train. We've dressed it up. We've introduced technology. We've studied it. We've made it more systematic. We've made it less biased. But at the end of the day, physicians are still trained the way that healers were trained 5,000 years ago. It's still an apprenticeship model. And I think it's important for them to recognize that there's something really powerful in that type of model.
I'm seeing something similar from the way you're teaching the course too, as well, like kind of bringing students in a way to be able to think critically about the content on one hand, but in the case of the E4C program, you're kind of teaching them to think critically about themselves and their own role, which is really cool.
Yeah, and not only themselves in their own role, but to think critically about the profession. I think they think about physicians and physicianship sometimes as a monolith that hasn't changed, but that's where I think the history of medicine really comes in to show how much it continues to change. That change can be slow, but if they want to change it, they can be part of that change. So there's sometimes this idealism that I think is both needed, but it also needs to be tempered, and it also needs to be channeled for them. And I think that's really challenging to sort of take this energy. They have so much more energy than I do. I like remember having that much energy and that much passion, but trying to really direct it into a productive forward movement for their own careers.
Well, as someone who teaches at this intersection of several roles, a clinician and mentor, preclinical and pharmacology thread lead, what is one piece of advice you have for faculty and curriculum designers who are training the clinicians of tomorrow?
Oh, that's a great question. I think I've thought a lot about this. I think as we've had conversations over the last 5 years, really about the introduction of artificial intelligence and what does that mean for the future of the profession, I think that's really made me think even more deeply about why do we have medical school and what do we really want somebody who's finishing medical school to have mastered or to acquire. And I think one of the challenges has been the sort of balance between understanding that our learners are adult learners, but I think sometimes the pendulum has swung maybe too much into giving them autonomy, but recognizing that these individuals still need a fair amount of guidance, not only in what they need to learn, but to set the standard for them. And I think that's really challenging because I think that concept has been an area that has resulted in individuals saying that the training in medicine is toxic or unprofessional, right? That unrealistic expectations are set of individuals, but that doesn't mean you can't have any expectations. And I think there's this balance to be achieved in designing a curriculum that truly challenges individuals, right? To be better than what they thought they could be. I often, even for not just curriculum designers, but even for students, I often use the analogy of like these individuals have generally performed really highly at something in their life, whether it be a sport, whether it be music, journalism, advocacy, etc. And I always say, like, what would it take to perform at the top of that field or profession? Like, what does a professional athlete do? What does a professional musician do? How much do they train? How much do they practice? And how much do they go back to their fundamentals and repeat them over and over again to continue to be at the top of their field? And I have to remind individuals, like, when you come to a place like Stanford Medicine, you're choosing to practice at the top of your profession. And so you have to really think about what type of commitment that takes. And that doesn't mean you can't take time for yourself. That doesn't mean you can't take time to be well. And if you need to step back, you step back. But it doesn't mean it's not a true choice, nor is it not a true commitment. And I think we sometimes forget that. We sort of think that, yes, anybody can do this, but it actually takes a fair amount of individual commitment from the students to be able to do this. So while, yes, anybody who's committed enough could come and become a physician, not everybody is able to, for sometimes choices out of their control or has the ability to make that type of commitment. But that doesn't mean we don't hold that standard for our profession. And I think as there's more and more threats to the profession, it becomes more and more important that we really guard the key principles of our profession and don't dilute those, because that's really what it means to be a physician, is to have that sort of higher level mastery of the material.
Well, thank you so much, Dr. Aggarwal, for joining us for this episode. If you'd like to explore more conversations like this, you can find our episodes on the EdTech YouTube channel. major podcast platforms, and in the Stanford EdTech newsletter. To learn more about our work with faculty and educational technology at Stanford School of Medicine, visit our EdTech website or reach out to our team. We'd love to hear what topics you'd like us to explore next. Join us next time in the Stanford Medicine Studio. Thank you.
Thank you.